Well, hello everyone. Thank you for joining us today for this special discussion on burnout among professionals in the health technology management field. We're going to call that HTM for the rest of the talk. And your local hospitals might call it something different, be it biomed departments and clinical engineers or various titles for service providers that go to hospitals to repair complex medical equipment. Today, we're joined by 6 professionals representing those various corners of HTM. So let's dive into introductions with the ladies first. Huma, would you please introduce yourself?
Of course, thank you, Brian. As you said, my name is Huma. I work for the VA healthcare system, Department of Veteran Affairs. I currently work for the Vision One New England Healthcare Center. I am the, as they call it, the cyber lead for Vision One. I work with a lot of network medical devices, vulnerability management, cybersecurity, risk assessments pertaining to medical devices.
Got you. And Colleen?
My name is Colleen Haugen-Ortiz. I work with GE Healthcare, prior Army BMET. Got out of the Army and worked my way up to a HTM quality specialist. So I came from the field and now work back office doing things such as training, onboarding, training documentation, auditing, as well as recalls and field modifications.
Got you. Great. Now let's transition over to the guys. Let's start with Chace, the bearded biomed.
Hi, how's it going, everybody? My name is Chace. I am also a prior Army Biomed, 68 Alphas lead the way. Served 8 years, got out, and I am now the lead field technician for the DFW office for South Plains Biomedical Services. Been there ever since. And also the host and provider of the Bearded Biomed podcast.
All right, let's go right over to Mike Powers, if you want to introduce yourself.
Morning, I'm Mike Powers, Clinical Engineering Director for Intermountain Healthcare. And I was not a biomed in the military, but I will go as far as to say go Navy, beat Army.
Got some rivalry here. And Michael as well.
Thank you. So my name is Michael Brilling. I have been in HTM about 10 years now, all of that within Dartmouth-Hitchcock Health. I currently manage our flagship hospitals operations teams of biomeds and our shared services, which we break out into the clinical engineers, our part sourcing, and our regional support biomeds.
And last but certainly not least, Mr. Paul Neher, who is not on a camera right now, but he is definitely here with us.
Hi, my name is Paul Neher. I'm a 23-year biomed. I'm currently supervisor of biomedical engineering services at Parkview Health Systems in Fort Wayne, Indiana.
Thank you, Paul. And I should also mention that I'm Brian Stallard. I'm the media relations manager for AAMI, and I'll be the moderator for this panel. Today we're discussing burnout within the HTM field, which is, I'm sure burnout's a word that you've all heard before. I mean, right now I'm looking at a recent hospital review report where it says that about 18% of healthcare workers have quit their jobs since 2020, and an estimated 60 to 75 of U.S. clinical staff report symptoms of exhaustion, depression, sleep disorders, and that's according to the National Academy of Medicine. The big question is, what about HTM, right? You know, a lot of the time we talk about these frontline workers, but HTM is certainly also an important part of the front line, just not one that's really talked about much. I'll just dive into it. Whoever wants to go first. Have any of you experienced symptoms of burnout in the recent past or watched anyone else go through burnout?
I'll go ahead and start. I myself went through burnout. That's partly why I chose to go to a back office position, was between commute and hospital demands. It was, you know, just constant day to day, back to back, putting out fires. So I definitely get the feeling of burnout.
Gotcha. Anyone
Yeah,
else?
I'll absolutely commiserate with that. I mean, I think for our teams, we saw it most acutely right up front. The very early phase of COVID was really challenging for our team. As we've settled into this is something we're going to live with, it's been kind of tapering off, and we've gotten better as a group at kind of riding that roller coaster and recognizing burnout, recovering, and getting back up to speed. And, you know, there's a lot of that that's still out there. You know, we have 2 to 3 times as much stuff waiting for parts just because of supply chain issues. That's more frustrated customers. Those are tough to deal with. That's tougher on our biomeds. These are just normal facts that are escalating right now across healthcare. I don't think maybe we have it as bad as anyone in healthcare, but it's certainly still out there.
I would chime in and say that we're also experiencing an interesting demographic trend that as people approach retirement age, we're seeing that instead of electing to stay engaged with the field and maybe work until they are kind of forced out by federal Social Security, we're actually seeing a lot of people opt out as soon as they're eligible for any sort of benefits. So I'm seeing earlier retirements as opposed to that 67 age group. And that's even with, we've got lower than ever COVID numbers. We're seeing things drop off. We just, got to one of those points this week where our flagship hospitals back under double-digit numbers or single-digit cases of COVID in the big house, and still we're seeing people struggle. And it's not just the I've been doing this forever, I think I'm ready to hang it up crowd. We have some caregivers with long-term COVID symptoms. So we've had people that have had to leave the industry because they've had like COVID-related asthma and things of that nature that are preventing them from being able to work in a full-time capacity.
I would piggyback on what Mike just said about that the burnout that we see within our department, we've got a good number of biomeds and we're scattered around, but our guys have worked through COVID just like everybody else's has. We've gone through all the stresses of the surges and the rapid deployments and instant builds of ICUs in places that were never designed for ICUs, but we had to do that to get the cases for the patients. And we're also in it's been a steady decline in COVID, flu's going up and RSV and all that, but it's almost kind of like the big exhaustion exhale. We've got team members have had COVID. They're tired now. They're like you said, Mike, we've had long-term health effects, especially in our older teammates. And the team is just at that point where everybody's ready to take a vacation. So now we're at the point of, we've come down. We're trying to get caught up, and now everybody wants, I think everybody just need to go through a round robin and 2 weeks off, just go around the board until everybody can recuperate. And that's kind of where we're at. I haven't had anybody say, you know what, that's it, I'm done. But what we do see is you could just tell the speed that they're moving, the way that the work is getting done, the attitudes in the shop is just everybody's ready for a break. We had a meeting with our leadership team, with the hospital leadership team, and they took a poll of attitudes and comments that people had about COVID, and the number one was, I think, I'm just done. COVID. I'm done with COVID. I want to go on to something else, and so I think that's where we're at.
That's an interesting point you're raising, because it almost gives us this perspective of that this burnout that people are experiencing right now is a very specific, almost I deserve this kind of burnout, right? Where they've been exhausted, but they stayed on because of the world pandemic that was occurring. And now that things are lightening up, people want to stop. I want to transition with that because I really want to dive into what each of you might define burnout, because that might vary depending on if you're a BMET yourself or you're higher level management, something of that nature. So I'm going to transition. Chace, I'm going to volunteer you, if you will. Will you give me a definition for burnout?
I would say burnout's a little bit different for everybody, but it's pretty reflective of you as the worker feeling overworked, stressed, swamped. Usually it's indicative of feeling like a mentally or emotionally draining, keeping up with the workload.
Great. Does anybody else want to tack on to that? Add any other factors?
So
I
burnout.
heard it.
Oh,
Go ahead. We're all very polite.
Go ahead.
I heard, and I think I accept a very broad definition that it's any employee who is not happy with the level of work-life balance they're able to put into play. So if you're past your chosen level or threshold, you're experiencing burnout because you would recognize the need in yourself to recharge or take more time for self-care.
Gotcha. And Colleen, do you want to add anything onto that?
So burnout to me is when you wake up in the morning and you're like, I don't want to do this. You know, you look at that phone alarm and you just want to click, you know, turn off the phone alarm and go back to bed. You know, you don't want to get up and go to work and do the day to day. You know, you just feel tired. You're over it, you know. And I think one of the big causes too, I think, is staffing issues. I don't know if you guys face that, but that, you know, is one of the big things that I've seen is and heard, you know, now in my position, I talk to 1,500 different biomeds, you know, from different shops. And I hear a lot on things like staffing issues being the big one.
And if I could add just one point is, I'd say burnout would be like not being even able to complete or even have time or have the energy to do just the basic demands of your life. Like you're just so exhausted and emotionally drained at the end of the day that you don't want to do anything else except put on Netflix.
I guess the thing I'd wrap up with, if we can, is biomeds tend to be highly engaged as a team. We always try and go above and beyond. We know the impact that our work has on patient care and on the caregivers that provide that care. We tend to be a very, very engaged group. And as we've progressed through the pandemic, I'm seeing levels of engagement drop off to, instead of going above and beyond, it's what's required. And that instead of giving 110% and you get a 10% more productive team, and maybe you have one less FTE, now you're having to look at classes have been canceled for a year because all of the manufacturer training schools have been closed. Well, now all the classes are open. Everybody wants to go to school. Everybody that's left is now working to make up for that person. And we're seeing, you know, just more and more, there's so much. And people are drifting with their levels of engagement.
Yeah, and something that was brought up during this conversation was we were talking about everybody is being understaffed. Even Mike, you're talking about, you know, you're giving that 110% because you're making up for something. Yeah, AAMI recently had their demographic survey that was late 2021, where we were talking about an estimated HTM departments were reporting that there was about an average of 8.5% understaffed or open vacancies on average, and it's taking 4+ months for about a third of them to fill those positions. I was curious if any of you thought that's also related to burnout in terms of people leaving their positions earlier than you might have expected, or, you know, this is also a known problem that HTM has been facing far before COVID-19. So is this just a burnout problem? Is this more than that?
I think, so me personally, I think that it's a problem that's being exacerbated by COVID. Like it was a problem before COVID, but now, you know, when COVID came about, it just sort of more people left the field due to various reasons like vaccine mandates. We've had people have to leave hospitals because of the vaccine mandates, you know, different things along those lines. You know, that it just exacerbated an already bigger problem. And then they're being filled by people who, you know, come from cable companies and stuff like that, that may, you know, so here you are doing kind of almost double work because you have to supervise them, you have to train them, you know, stuff like that. And that takes a while, that takes time. So, you know, you're getting even more burnt out because, you know, you're training, you know, John Doe over here how to turn a wrench. You know?
Mike Powers, you want to add on to that?
We're seeing a lot of the same thing, that we'll have a highly tenured CE3 that will choose to leave the workforce and enjoy their retirement. And partnering with AAMI, we just hired our first apprentice, but now we're replacing a CE3 with an apprentice. And even though they're highly engaged and they're intelligent, passionate, and want to help, there's just it's not only a system and a technology education gap that we have to fill and start training and budgeting, but it's also just knowing who all of the nurse managers are, knowing how to communicate in a way that not only fixes a device, but fixes a nurse's relationship with the device. Knowing all of those things is a big change, going from a highly tenured senior engineer to a brand new apprentice technician.
Got you. And then I'm guessing that puts a little bit more pressure on the rest of the department.
Yes.
Michael, you also looked like you had wanted to mention something.
Yeah, I mean, I think we're in the same boat. This is a really terrible experiment because we can't separate these multiple forces that are happening. We were saying 3 years ago, before COVID, that you don't get to hire senior biomeds. If you can't build them, you can't have them. And so we're building the pipeline, and then COVID hit, and we absorbed some hospitals, and we went to about a 40% team expansion. We added a shift, and that whole shift and whole team is all new biomeds. And so it's just a training center. We call it a biomed shift, but it is 100% training new technicians. And we've been rolling folks from that shift to the rest of the shifts constantly. And so you can't separate COVID burnout from the damage that's already been done to the industry, from folks who said, this is not a supported team, I'm going to go somewhere else with my career. And now they're in research, or now they're installing solar panels. We've had to fight those fights, just like Mike is mentioning. We can't compare our biomed techs just to other healthcare biomed techs. They are technologists. They don't need to work on medical equipment. They have the skills to work on many kinds of equipment. And so these are all really common factors, but it's really impossible to have a discussion just about COVID burnout because they're all happening at the same time. And we all know there's a very serious shortage of those tech threes. Those, 50 plus professionals are looking at retiring, and they're retiring at greater rates. And we're not really filling them with folks in their 30s and 40s who are in the Tech 2 range. We're filling them with new biomeds. And I think that's a common experience. So we're all...
So you've noticed that when you're looking at the job listings that it's all for like Biomed 1s, but those are replacing the Biomed 3s that left. And you're just kind of sitting there going,
We always post a 3. In this whole expansion, we haven't hired any. And it's not because I wouldn't love to see them.
Kudos for recognizing that. I've discussed this on almost to exhaustion on the podcast with many of my guests, that we're not going into investing in the future of our technicians, especially as you had mentioned, median age being over 50 years old. And we're seeing, each year, the HCF salary survey, the AAMI demographic survey, it's showing that we have 5,000 to 6,000 more technicians we're going to need, I believe, by 2028. And we're not meeting those demands. Obviously, with retirements coming along and technicians not being invested in, that's also why our field is very synonymous with having issues with retention, because we're not investing in, providing fair pay for the workload that you're putting on your technician, career opportunities, especially education opportunities. And then, like I said, you're putting in a technician 1 in a position that really needs probably a 2 or a 3 at most, and it's not translating. So I think across the field, especially in field service, I'm seeing this a lot.
And I'm sure
Agreed, 100%.
Paul, do you want to say anything else?
I don't want to get off topic because you're opening my current life right now. We're sitting with, in addition to COVID issues that we've had, as we've already discussed, we got a 25% retirement rate coming up within the next 5 years. And we in Biomed have been talking about this for 10 years. You know, as we looked at the baby boomers, we all knew that was coming. You know, the baby boomers are starting to come into the hospitals and we're getting ready for a retirement surge. Well, now we're at the beginning of the baby boomers. We just got through COVID. We're now through a RSV spike and a flu spike. And we're also sitting on the cusp of a huge retirement thing. So, you know, we're talking about, you know, the original topic of burnout. The team is feeling what's coming. You know, they've struggled through and outperformed through all this COVID surge. And now our task as leaders is to keep them buoyant, knowing what's coming. And we're in the same boat. I've had positions open for Biomed 2s, just trying to shoot for the middle and, you know, hope for the stars. And we're hiring ones because I convinced our management team that we need to invest. We need somebody who's going to be able to come in that we can train for a long-term investment within the department. And that's the reality. The biomed schools stopped cranking out biomeds. We're back to where we were 20 years ago, hiring techs who have tech skills and customer service skills that we can train as biomeds. And that's kind of where we've came to that reality. We looked at the future. We looked at what's coming and said, look, it's time to start investing before the retirements happen, not after the retirements happen. So keeping the team buoyant through that is how we're trying to address burnout, because they're looking at the future going, oh my gosh, here we go again. And so that's the challenge. So if anybody has a golden key on that, let me know.
I would be remiss not to mention, since it was brought up, that AAMI does have the new BMET Apprenticeship program. But that said, the BMET Apprenticeship program, and I'll link more information to that in the description of this video after we're done here. But you know, that's only one step towards this larger issue that you're all talking about, that everybody's you know, a little worried about right now. We need participants, and it's only going to bring it's focused on entry level. So, you know, there's going to be a lag, and I'm sure that's putting pressure on everyone. That actually dives into, kind of dovetails into what we were next going to talk about, which is, you know, factors that are contributing to the burnout within your own department. So it sounds like in a lot of ways, trying to find new talent is a very important factor, because it's adding new pressure. Huma, you had your hand raised there. Did you want to add anything onto that, talking about factors?
Yeah, and I think it could also relate to the last topic we were discussing, is taking on, like, Biomed has, I mean, I've been in Biomed field as a clinical engineer for the last 6 years. So just seeing the growth of cybersecurity with medical devices, taking on that role for Biomed, I mean, in the last 10 years, we've been, that whole field within clinical engineering has changed a lot. We're taking in more roles than just fixing the equipment or, you know, working with the clinicians. Those additional responsibility, I mean, can cause stress, because I don't know about the different hospitals that the panel here works, but as far as VA, a lot of that responsibility falls on Biomed. So we need people who have additional skills within, like, IT, with computers, servers, and that's not something that's usually taught within the Biomed field. When I went for my undergrad, there was never, like, any topic regarding cybersecurity when it came to medical devices. Same thing with my master's. So, like, transitioning into this role, there's a lot of, like, almost say, like, education. There's a gap when it comes to Biomed and cybersecurity, and a lot of this falls on that individual, on the department, to be able to fill that gap. So I think like, those types of additional responsibility that falls on our shoulders aren't usually talked about. So yeah.
So I'm finding almost the opposite with regards to cybersecurity. And that's mostly because a lot of the tenured staff that we have entered the field back when you could take a vacuum tube to Radio Shack and check it in the vacuum tube checker.
Radio Shack.
Then there was the whole IT field came into being, and that technical person who understood, what all the stripes on a resistor are, that person went into the IT field. And now with the arms around cybersecurity of medical equipment, I'm finding that we can actually capture some people into clinical engineering that historically had migrated away from biomed work into IT, because now there's a home for that skill set. Knowing an OSI model is now relevant, and people can actually find a home that speaks to their talent.
I just wanted to caveat
really
what both
agree.
of y'all said. The days of the biomed just working on a piece of medical equipment are gone. I mean, there's a lot more. There's device vendor management, cybersecurity, as Huma spoke about, facility projects, regulatory compliance. The list goes on, and the field needs to recognize that this is also going to contribute to burnout. If we're tacking on more and more responsibilities as a biomed, then we also need to accommodate for that. Luckily, a couple of the things I've spoken with is, for one, David Brodahan mentioned that his Biomed program here in Texas, they are implementing computer and IT classes for the Biomed students. And I also spoken with Sergeant First Class Tarpley. He's responsible for the subject matter expert for the 68 Alpha Field in the Army. The schoolhouse is also starting to implement IT training as well, at least on the military end. So it is being recognized, but I don't know if it's going to come fast enough. Hopefully that recognition of that need is going to be facilitated sooner rather than later.
Michael, you had looked like you would also wanted to tack on something there.
Mostly just agreement. I also find it's a recruiting tool, and we're pulling in folks with IT backgrounds pretty intentionally. It's a nice stepping stone from other IT positions within the hospital. We're fitting that middle ground, and I think everybody, ACC, AAMI, all the education sides are trying to figure out how much networking versus how much hardware and how much cybersecurity a biomed really needs. Where is the line between biomed, clinical engineers, security professionals? Is it just device hardening, or is it really the network protocols? Where that line is changes at every organization. You got to know that to know how to train your staff and where to fit into. Go ahead.
No, sorry, go ahead. Finish your thought and I'll go after you.
I'm okay.
Okay.
But he's so polite.
And so one of the things I wanted to add was I've noticed that it's working in a medical device field, or like in a clinical engineering field, it's a little bit different. The mindset is a little different than someone coming from an OIT background. So it's just, I think sometimes it's hard to be able to transition into that role from like an IT background. Just wanted to add that thought. So
I wanted to add what Chace brought up about the tacking on more and more responsibilities onto the biomed tech. That right there, I've been seeing that more and more, where the biomed tech went from, just being responsible for the piece of equipment to all of a sudden, we're dealing with switches, we're dealing with a lot more than what it used to just be. We're now, side projects constantly. There's constant side projects going on in a hospital nowadays, where it's like, oh yeah, we need you to move this department. We decided to change it from a trauma department to an ICU or something. So we need, you have to make up for these types of things, or we're changing it from a med surge to an ICU. So then there's more requirements to that, installing, different equipment to accommodate those requirements on top of your day-to-day PMs and, repairs and constantly having to babysit the phone, documentation, which on my end, I audit documentation, and I felt like that was a huge indicator to me to see burnout, when I'm documenting documentation and, you know, I'm going from a few bad ones out of my list to it's getting worse and worse and worse, because the first thing that's going down when you're looking at burnout is who wants to document their crap?
It gets lazy.
Exactly. But it gets worse, worse, worse. And you can tell just by looking at that they're getting more burnt out, because that's the first thing that's going to go. First thing that's going to go is your documentation. You know, they're going to, you know, still face the customer and stuff like that. But, you know, they don't want to take the time to sit down and actually like write out what they're supposed to write out. You know,
I think the way that HTM as a field is leveraged in hospitals and or even healthcare delivery field areas is changing because of the way that COVID has forced us and how we're going to change that episode of patient care. Now we are
A
keeping
multi-tool.
track, keeping track of, you know, all the PAPRs that everybody had to wear. There's devices. We're sending people home with oxygen concentrators. We're looking at all these things that the way we delivered patient care is changing. And because of that, you know, here we are, 21st century, the way we deliver patient care is changing. So one of those changes is we have to make data-driven decisions. Everybody's excited about data-driven decisions, but that comes from, like Colleen was just saying, lots of data. And data has to come from taking an extra minute to make sure that a work order is closed correctly, that it's coded correctly, that all of the parts costs are captured, that your time is actually documented correctly and in a timely fashion. So moving towards a different way of leveraging an HTM professional includes a growing reliance on data-driven decisions, which then encumbers all of those team members to not only have to do their job, but then to document it, and then maybe document it even more than they ever have in the past, so that we're capturing those unique insights like trending parts costs and things of that nature. So it's interesting that as we've changed how we deliver patient care, that's also impacting how the HTM shops are able to support the caregivers and the equipment.
I mean, you're using the documentation not just for that, but also for manning. You know, you're using that to track, like, okay, does this site need more help and stuff like that? But here's the problem. If they're so busy that they're not documenting, it's hard to track if they need manning. So it's a catch-22 right there. You know, you don't.
I'll take that point just to bring up AAMI right now. There's a program, a project happening where the CMMS service providers are working together with HTM departments to try to standardize certain fields to help make that data more, you know, understandable and shareable, so you can actually have a benchmark point of comparison. But one of the things that they brought up recently is they actually wound up their second white paper. They had to wind up standardizing the work order field, a work order type field, to define what that work order type is. Because as you guys are describing here, it's more than just preventative maintenance and repairs. There's suddenly all these extra areas that nobody really knows how to define, and they don't really know what's going, you know, you all might describe these things differently. So, you know, AAMI's demographic survey said that we have 1,700 total work orders on average per Bmed every year, which seems like a lot of work to me.
More than that.
But it's exactly, it's
Yeah, I was
it's
about to say
actually more than that. It's other things that you can't define as just preventative maintenance or planned maintenance as well. Yeah. But
Scheduled
so
maintenance, planned maintenance. I mean, I've seen it across the board.
So we're talking about these factors that are contributing to burnout here, and it does sound like it's also because these responsibilities are growing, and there's not the best way to manage it just yet. Is it because the field itself is evolving too rapidly for people to keep up with?
I think it's also how you define your department versus another. For example, at a nearby health center, all the interfaces to the EMR are owned by clinical engineers, and the folks who do that are clinical engineers. At my particular health center, the clinical engineers manage the device out, and then an interface engineer owned by an interface team does the integration to the EMR. That's not in our scope. It's not right or wrong either way. I really like it because they have a huge depth of knowledge, whereas our clinical engineers have to do a lot of things. It happens to the biomeds the same way. Do you throw a biomed at IT equipment because it's in a patient room because they're on site? Or is that out of scope because it's not a medical device? That answer is not consistent at every medical center. And so how do you do work orders? What is your work order type? Do you even send the same people to the same request as every other facility? And so lots of these things are very much gray area. And that's okay, but it's hard to arrive at standard answers because everybody draws the line a little differently.
Paul, you had your hand raised there.
I agree absolutely with what Michael just said, and it's kind of what goes back to the heart of hiring. It goes back to burnout. It goes back to HR integration. It goes back to recognition and compensation. We within our healthcare industry, we all do our shops differently. We all manage our resources and what is in my scope, what is not in my scope, what fits that little job description that says and all other duties and as assigned. Our particular department, we are part of IT. Some departments fall under maintenance or facilities. Some are standalones, and they all have different rights and responsibilities. And one of the things that we find, I was just talking to my crew this morning about, what is their primary issues with burnout and what helps and contributes to that effect. And it was job description, how we are viewed as maintenance as opposed to equipment management or technicians, or we have the same job qualifications as IT because we do a lot of those same things. Like our team, we integrate the devices to the EMR. IT controls the EMR head end and the translation for that, and then we control the output from that. So we have two pieces of it. We analyze and diagnose alongside with our IT counterparts what's going on and how that's talking. It's not just, guy working in the back on suction regulators. Now we're talking about the flow of data and controlling that from both ends of that. So the teams are doing many varied responsibilities that are not in the generalized description of what a biomedical engineering technician is, or a healthcare technology management technician, or an IT, information systems analyst. It's all just a mishmash, and it depends on your facility. So trying to come up with something, when we look at job scales, we compare ourselves to each other, but really that's still apples to oranges to grapefruit, because depending on the department that you're in. So there's a lot of that still contributes to the original topic of, why are our teams so burnt out? They're burnt out for not being appreciated or overused or just COVID. We talked about COVID brain this morning. We got guys standing in corners looking at the walls because they can't figure out what we're doing today. So there's a lot of those pieces all come together. But I think that variance has got to make it hard for somebody trying to standardize for our field when our field isn't even standardized.
I just want to touch on that. Like, you make a good point that we have so many different monikers for what we do, and everybody has a different, adjective or, name of what we are. Amy's done a good, campaign of creating the HTM scope. But still, we refer to ourselves as maintenance whenever we come in to work on something in a patient room or, a biomed or what have you. And this also goes back to general society not recognizing of what a biomed or HTM is. So we have to do a better, job at educating everybody of what the responsibilities of what we do is. Like I said, that's going to come with time, but it's a growing fight that I'm sure everybody is trying to define, with their particular departments or their facilities as, hey, this is what my responsibilities are. And we just have to, create recognition of that.
Kind of have to start at the C-suite on that one. Because let me tell you, some of those projects where they're like, oh, why isn't this done yet? Well, I'm waiting on IT. I'm waiting on maintenance.
Most biomeds are introvert to begin with, so we try to avoid C-suite and politics anyway.
We try, but when they call down, hey, I'm waiting for this, and I'm like, Wow.
That's why I'm field service. I like to stay out of the internal politics of hospitals.
Now, I think we could take a moment here. We've dived into really the diversity of what might be contributing to burnout, but I wanted to ask you guys about any personal solutions you might have for your own burnout. How do you prevent it? How do you recover from it? Does anybody have suggestions?
So I have a.
Go ahead.
I mean, everybody has their own rituals that they use to combat their, burnout, whether it's mental, physical, whatever. I just kind of, first wise, I prioritize, my expectations and base them on urgency. My issue is I get into a lot of multitasking and taking a larger workload, and I kind of lose sight of that sometimes. So trying to stop and reevaluate, what needs to be done and prioritize. I cannot get that word, can I? And then, setting aside personal time to take full advantage of, reattributing yourself. I'll get into the gym, pick things up, put them down, get home, and I'll dive into, my personal, loves, video games, podcasting, spending time with my fiance. It's really about setting time, whether during the day itself or personal wise, to, recognize what you need to accomplish and just, revitalizing, I guess, at least for me.
Can I say transparency? How can we expect our leaders to know how, what's going on if we're not transparent with them? And as leaders, be understanding of that too. Be understanding that, hey, my tech's tired. They might need a mental health day every so often to, get through that. But my own personal one was finding a position that fit my needs. And also I am a lister. I have a notebook. I list all of my responsibilities for the day in my notebook, and then just kind of tackle them one by one.
I see a lot of hands up. Before we transition to the next speaker, I did want to ask, Chace, you had mentioned Colleen had mentioned transparency, and Chace, you mentioned recognition. I'm curious if you think if people were more aware of what the biomeds, the Bmeds are doing for their hospital and their colleagues in the hospital, would there be less burnout? Would they feel less like
Well,
what they're doing is useless?
We've all heard, the quotation, the unsung hero of the hospital, or the ninja biomed, or something along those lines. Of course, this goes back to educating, your staff that you work with, or, the hospitals you visit as a field service tech, of, provide recognition for your value, and yourself, and then also for the people you work with. And obviously, whenever we feel good about what we're doing and other people, show appreciation for what you're doing, you're more prone to feel a little bit better about that day. I know whenever I get a thank you or a, hey, we appreciate you, that burnout or whatever stress that was inhibiting me at that time tends to, go to the wayside, just because I feel appreciated as a technician. So yeah, I would say, recognition of what a biomed does and showing appreciation to the biomed is, going to help alleviate that just a little bit, but it's not the end all solution.
Gotcha. Mike, I saw your hand up. Go first there.
With how to combat burnout, I think for me, it comes down to communication, and whether that's communicating my needs, whether it's asking my team about their needs, whether it's asking our clinical caregivers about their needs with the equipment. A lot of that comes back to communication, whether it's communicating gratitude, thank you for coming in and repairing this over the weekend, or even some of those like water cooler talks that you just would have. Okay, now we're able to stop and ask someone, how was your weekend? How is your child doing? Did they have a good time in that play that they had signed up for? Did they learn to speak and run and ride a bike yet? All of those kind of things that we took for granted maybe before COVID. Now trying to be socially distanced, the opportunities for communication whether it's about equipment or people's needs or expressing gratitude or just checking in and expressing how you give a hoot to somebody. All of that seems to have kind of diminished a little bit with COVID. So I find that one of the best ways is to try and over communicate with everybody that I come in contact with.
Great. Huma, I'd seen your hand go up next.
Yeah, I just want to echo on a lot of the points they, Mike and Chace and Colleen made. Transparency, communication. I think those are very important in recognizing the work the staff are doing. Some of the smaller steps that I take just to relieve like a quick burnout is like Chace said, go to the gym, right? So small stuff like that, just sometimes shutting down my computer and not just looking at my work, sometimes being able to draw that line between your professional work and personal life. So it's difficult. I'm not going to say it's easy to do, because sometimes you're like, no, I have to do this. It's due tomorrow. Or because a lot of the work that we do affects, at the end of the day, affects the patients. So we always have that sense of urgency to be able to complete this task or the next task. So prioritizing, like Chace said, is really important. Even though, like I said, at the end of the day, a lot of our work deals with, at the end of the day, it will affect the patients, but just being able to know which one is like, from even a manager perspective, telling their staff, hey, this is more important. This is the first sec. If you could try to complete it within the next 2 days, like, I think it's usually great to have that communication between like the manager and the team. So.
Michael, you want to tack on to that?
Really great points raised. I agree with everything that's coming out here. Colleen, I think you asked a really important question, which is how can leaders create that and recognizing that staff. I think for departments where this is a change of culture, in acknowledging this kind of engagement, this kind of burnout, these additional kind of emotional communications, the leader's role is to normalize that communication. And it's hard to find those opportunities, but taking those moments to say, I'm really struggling to get my head in the game today. This is the thing I have to do, and I know it. I'm going to go hit that wall right now with you, gives the okay for other people to have that experience and then to communicate that back to you. And that's how you know where your teams are at. And if we can't exemplify that behavior, we can't really expect it out of our staff.
What about you, Paul?
Michael, spot on. My team, like I said, we've had our own health issues within our department, and I was rewarded the other day by we had a team member who was out for 3 weeks, and it was touch and go. When he came into the shop, the whole shop just erupted in cheers, welcoming back a team member, and that kind of camaraderie. It was amazing to hear. I've been in shops where there was enough infighting and backbiting, but that's not what I saw. Even with the burnout, everybody was just, man, he's back. Thank God for that. And it wasn't just because it was a team member that was going to take some of the load off of us. They were genuinely worried about him. So that was an amazing team moment that was outside of the day-to-day. Well, the way I've been able to help these guys combat burnout really has been going all the way back to the roots of what I was always told of leadership. Helping them when COVID brain is hitting and they just don't know what to do next. Giving, like you said, giving that guidance. This is prioritizing their day for them and helping them along, and then just watching them take off with that, because all they just needed was somebody to make that connection. Taking on some of the responsibility of the mundane tasks that they just don't have the energy for, showing that leadership example. But then you've got to find a way to deal with that yourself. Me personally, I live 45 minutes away, so I have a daily detox, my long drive home, that I can just stare out the windshield, not think about anything, and just let it go before I get home, take care of the kids and wait for the weekend when I can have some me time. But it's a different kind of work-life balance that's really needed, and giving each other a heck of a lot of grace. Letting playtime in the office run longer than it probably should just because they need it. if we, control those vents so too much, then that energy and that anxiety bottles. So giving each other grace and helping each other through the day, like you said, it goes a long way. It's kept the shop from self-destructing because, we've got a mix of young guys and old guys within our team, and it can be stressors in and of themselves. So it's helped, just helping each other along, helping each other with projects, helping each other do even the most mundane tasks has really helped them coalesce so that it doesn't become that, oh man, I just can't do this.
I'm curious, we're approaching time here, but I did want to wrap it up with this discussion about responsibility for dealing with burnout, right? You all have strategies for yourselves, but you're also talking about ways the leadership can help. How do we, assign that responsibility? Is it something that leaders should just say, okay, I got to put time in my day every day to address burnout in my team? Chace, you got your hand up.
Yeah, I'd love to touch on that. So I think for the most of us, we, as a technician, you had the mindset that you are responsible for handling your business. You handle your mental, emotional bandwidth. But while a technician should be the master of, their own burnout, it also falls on a manager as well. As a leader, you kind of have to ensure that your techs are set up for success, making sure you're not overloading them with work assignments, allowing opportunities, whenever they need to recalibrate themselves. Make sure they're receiving ample, opportunities, bonus raises, training that they need to, make them feel like, they belong here, that they're being provided for. And then I think the central theme of this is managers communicating with their teams. It's a little bit more difficult, I would say, for field service, just because at least my team, we only meet on a monthly basis. And, for the rest of the time, it's windshield time, and, we're working by ourselves. One of my biggest gripes with, tackling that is, for the most part, performance evaluations and counseling and that kind of deal is only done on an annual basis. And if you take the example, let's say the U.S. military, the Army does monthly counseling to where, you sit down with your technician, you feel what, their needs are, what their goals are, make sure that you're both running on this, the same bandwidth. I'm not saying we need to do monthly counselings or anything, but I'm saying we could probably sit down and at least evaluate where our technicians are standing from a communication standpoint.
Chace, you were in a totally different army than I was. Monthly counselings.
I was the one doing them. I made sure they got done.
You were a good leader. But I feel like there needs to be transparency with the leader and the tech. It's a two-way street, I think the tech needs to know everything that's expected of them, not just have it thrown at them last minute. I find that if I know the why, then it's easier to do the task. And I feel like a lot of times the why is left out and you're just told to do this.
Yeah, I would say that we are looking for ways to build collaboration with our teams. And as everybody gets a little bit more burnt out, you start shortcutting little things. And that leads us to, well, maybe somebody defaults to micromanaging or intrusive leadership, or maybe they start ignoring some of the things going on with their team under the guise of, let's give them a couple more minutes of playtime so that they can recharge. There's all of those things that as leaders, as people who expect things from leaders, there needs to be more collaboration, not less. And you should have a voice in, well, what projects am I going to get assigned to? You should have a voice when, if we're looking to send somebody to school for this new patient monitoring system that's coming in, well, let's make sure that we're selecting people based on their interest and aptitude and bandwidth, and so that we're having a discussion that goes two ways, as opposed to kind of just tagging people and saying, congratulations, you're getting voluntold, as you said earlier, to be selected for this opportunity.
I think that's a great point to wrap up on. It is 1:02, so I know a lot of you have a lot of responsibilities, so please don't get burned out because of this call. But I thank you again, everybody, for joining us today for this panel on a really important subject matter, and I think we dived into some really, really good talking points. Thanks again, and we're going to wrap this up.
I just appreciate meeting all you guys.
Thanks
Yeah.
for inviting
Gals.
me.
It was nice meeting you all virtually. Thank you all.